And it's very important to say that these lipids are quite essential for life. They are part of the cells, they are part of hormones, they have the capacity to store big amounts of energy, and it's important for survival, right? So, but fats, the thing is that fats don't mix well with water, right? They cannot travel freely in the bloodstream. That's where the concept of lipoproteins come in. These are like little transport vehicles, like tiny particles made of fat and protein, and they carry lipids through the blood. And each lipoprotein has different roles and structures, and they are classified by their density. And we call them chylomicrons, the VLDLs, because is very low density lipoproteins, IDLs or intermediate density lipoproteins, LDL, the low density lipoproteins, and finally the HDL or high density lipoproteins.
Coffee made in machines at the local hospitals, at least in Sweden, how they make coffee in those machines. They produce coffee in such a way that caffeistol, for example, which is a compound that is inside of unfiltered coffee, then
Okay.
it was present in higher amounts, and that resulted in increases then in LDL cholesterol. So I guess
Wow.
it might depend on what type of coffee, and particularly how it's prepared. If you were to give the listeners 1 to 3 pieces of advice for how they can live their life so as to reduce the risk of developing, well, high cholesterol levels, and then with that risk for developing cardiovascular diseases later on.
So check your lipid levels. Second, uh, it's very important to think that if you have high levels of cholesterol, the longer you have high levels, the higher the probability of developing atherosclerotic cardiovascular disease. We have enough information about the importance of having low levels of LDL cholesterol for reducing the risk of atherosclerotic cardiovascular disease. Third recommendation is please don't forget the other risk factors, right? The main problem behind all the cardiometabolic diseases is obesity.
Welcome, Daniel Elias-López, to the Exploring Health Medicine podcast.
Hi, David, and thank you for inviting me. Let's do this journey in this conversation.
Absolutely. Would you like to introduce yourself to the listeners?
Yes, of course. Well, my name is Daniel Elias. I am a Mexican endocrinologist with a background in internal medicine. I train in Mexico City, where I specialized in endocrinology. And later, I pursued a master's and a doctorate in medical science. But to further expand my expertise, I complete a 2 years postdoctoral stay in the University of Copenhagen, Denmark, under the supervision of Professor Bo Nordesgaard. Yes, and well, over the last decade, I have a focus on cardiometabolic diseases, first as a clinician, but later as a clinical researcher. Particularly, I have been focused on diabetes, obesity, dyslipidemia, because as you may know, these are big health problem in the world, but mainly in my country. As an example, the prevalence of overweight and obesity in my country almost reached 75% of the entire Mexican population. So it's really big problem. So yeah, I have done some research in these areas, publishing some scientific papers, book chapters, and that may help in understanding this condition. So I want not only to study these diseases, but also, and well, I'm not sure, but an ideal world to find better ways to prevent and manage them. Uh, as you know, this is not easy because these cardiometabolic diseases are really, really complex because they have a genetic background, right? But especially if environment factors associated with their development.
Yeah, yeah, interesting. I had no idea that obesity was so prevalent in Mexico, actually.
Yeah, the combination of overweight and obesity is 75%. I
Right,
mean,
right.
3 in 4 people. Yeah, it's big.
Yeah. And today we're talking specifically about hypercholesterolemia, right? Like high
Yes.
cholesterol levels. Yeah.
Yes.
Um, and you've done some research in this field as well. Would you like to share from your perspective, from a high level, from a zoomed out perspective, what uh, has been your contribution to the research in this field?
Yeah, I have been really interested in lipid disorders. We have in Mexico, in the hospital where I work, we have a lipid clinic. So we work with people with genetic lipid disorders, but mainly with secondary lipid disorders due to diabetes, obesity, metabolic syndrome. So for me, it has been a challenge because it's quite difficult to treat these people. So I when I was seeing those patients, I realized that I was making an impact on less than 0.001% of the population with these disorders, right? So that's why I was interested in doing research because I think in that sense I may help more people. So yeah, I have been working in trying to understand the some differences in lipid disorders in the Mexican population compared with other ethnicities, right? Because uh, we have many information about these disorders for example, in Europe and North America, but in Latin America we don't really have enough information. So for me, it has been uh, it's a very, very interesting topic because in Mexico, we also, like in other countries, we combine the genetics background plus all the environmental factors. So, yeah, I have tried to work in those. Well, yes, on lipid disorders, not only hypercholesterolemia, but also maybe hypertriglyceridemia and other lipid disorders.
What was that other lipid disorder that you mentioned?
Hypertriglyceride, the high levels of
Triglycerides. Yeah,
triglycerides.
I
Yes.
see. Yeah. Okay. And so you mentioned that you went into research because you wanted to have an impact on more people than you could in your clinical practice. Um, from a personal uh, point of view for you, why did you go into this specific field of research?
Okay. Yeah. As well, it's interesting. As I have mentioned, I come from a country where cardiometabolic diseases are quite common and prevalent, and I have seen firsthand how these diseases impact on people's lives, not just
I
in the
see.
hospital,
Yeah.
but also in everyday situations, right? So. Um, I have I have had some friends with complications related of these conditions, often because they weren't uh, diagnosed early or didn't receive the right treatments. So those experiences made my research feel very, I can say, personal, maybe, and urgent. Yeah, I realized that doing clinical research and answering important clinical questions, I could help more people that only seeing them, right? So I would like to help generate knowledge that can actually improve clinical practice and improve prevention, especially in population that are often underrepresented in research, like the Hispanic population.
Mm, mm, I see. Okay, so let's move on to the different types of cholesterol. Uh,
Okay.
and let's give the listeners some definitions for the main types of cholesterol. So I'm thinking HDL, LDL, remnant cholesterol. Um, let's start with those.
Yeah, it's I mean the lipid the lipids is really uh, complex. I can say the metabolism is complex. Even though we have many studies, it's still very complex. So yeah, I will try to make some key definitions about lipids. But to really understand these the differences in all the particles, um, I think we could start with some basics. First of all, I have to say that we have different types of fats that we can also call like lipids, and they are cholesterol and triglycerides. And it's very important to say that these lipids are quite essential for life. They are part of the cells, they are part of hormones, they have the capacity to store big amounts of energy, and it's important for survival, right? So, but fats, the thing is that fats don't mix well with water, right? They cannot travel freely in the bloodstream. That's where the concept of lipoproteins come in. These are like little transport vehicles, like tiny particles made of fat and protein, and they carry lipids through the blood. And each lipoprotein has different roles and structures, and they are classified by their density. And we call them chylomicrons, the VLDLs, because is very low density lipoproteins, IDLs or intermediate density lipoproteins, LDL, the low density lipoproteins, and finally the HDL or high density lipoproteins. But what makes each one unique is not just the lipid content, but also the apolipoproteins on its surface. Uh, and those are proteins that allow lipoproteins to be transported in the bloodstream. But also, and this is very important, these apolipoproteins act like we can say like an ID tags and docking instructions. So they help lipoproteins interact with other cells and with other enzymes. For example, ApoB, it's this apolipoprotein is found in the LDL and remnants, uh, but the ApoA is found on HDL. Well, now talking about lipid metabolism, for example, after we eat, our intestines produce a lipoprotein called chylomicrons to transport the dietary fats from intestines to the body and finally to the liver. It, however, but also very important. Also, the liver also produces some lipoproteins, for example, the VLDL particles, which carry mainly triglycerides. And these triglycerides are delivered in different cells to obtain energy. As these VLDL, which are really big particles, losses triglycerides, they become smaller, and after they are a very big VLDL, they become IDL. They are smaller, and the amount of triglyceride is lower, but the proportion of cholesterol is higher. Uh, After that, they are smaller, they can become remnant cholesterol, and eventually they come LDL, which is very, very rich in cholesterol. But on the other hand, HDL, the high density lipoprotein, works on the opposite direction, because HDL mainly helps pick up excess cholesterol from tissues and brings it back, yeah, to the liver, right?
Right. So HDL brings excess cholesterol to the liver from tissues,
Yes,
and LDL brings cholesterol to tissues.
exactly. The VLDLs and chylomicrons, they deliver triglycerides to the tissues to obtain energy or for storage, right? For example, in the adipose tissue, those triglycerides are stored. But for example, in the muscle, the triglyceride can be converted, yeah, in different substances to produce energy, mainly during fasting.
Right. Um, so just to clarify, there are these particles which contain either LDL or HDL or VLDL, right?
Yes.
Or chylomicrons or remnant cholesterol. Now, they also contain triglycerides, right? All of these. Yeah.
Yeah, the proportion is different. Chylomicrons and VLDLs, they are mainly, they carry mainly triglycerides. And after those triglycerides are removed from these particles, they become smaller with less triglycerides, but with more cholesterol. So finally,
Yeah.
so I mean, it's a continuous, right? So they are not different particles. They start like here, very big, and they deliver triglycerides in the body, and they become smaller. And finally, LDL cholesterol, it has only few triglycerides, we can say, or we can say nothing cholesterol, and they are mainly cholesterol. So that's why this cholesterol should be removed from the bloodstream by the liver.
Right. But we usually talk about these different types of cholesterols, right? But it's really just the same cholesterol, but in different uh, densities of particles.
Exactly. Yeah.
Yeah. Yeah, I see. Um, can you elaborate a bit on how the bad cholesterol, which is usually what LDL cholesterol is referred to, right? How does LDL cholesterol contribute to ischemic heart disease? Um,
Yeah, exactly. Well, the thing is that I would like before going this point, I would like to differentiate two other important things. We have HDL cholesterol, that is the good cholesterol, right? And we have non-HDL cholesterol. Non-HDL cholesterol include all the potentially atherogenic particles. And so it means that non-HDL cholesterol is LDL cholesterol, remnant cholesterol, and LP little a, or lipoprotein little a. So though all the atherogenic cholesterol, it can be calculated by non-HDL. And the HDL it's quite different, and apparently HDL doesn't have an important impact on heart disease, right? On atherosclerotic cardiovascular disease. So, uh, the problem is not LDL cholesterol or remnant cholesterol per se. I mean, as I have mentioned, we need that kind of cholesterol for life, right? It's important for hormones, for the brain, yeah, vitamin D. So it's quite important. The problem come when these particles, uh, the levels of these particles is quite high, or when these particles or when this cholesterol stay longer on the bloodstream. So those things are very important in the development of atherosclerotic cardiovascular disease or ischemic heart disease, because when those the cholesterol content on those particles in LDL cholesterol and in remnant cholesterol, uh, these particles can penetrate the endothelium. They stay there long time, but after that they can generate an inflammatory response, right? LDL cholesterol, they need some important changes to be oxidized, but remnant cholesterol, they don't need a change because they are really very oxidative, so they stay longer. And a very important inflammatory response occurs in the lower layer of the endothelium. And yeah, in the long time, it may develop this atherosclerotic cardiovascular disease, right? Because with time and with high levels of LDL cholesterol and renal cholesterol, there is a plaque on the endothelium, and this plaque can grow, and at some point after many years, it can trigger an cardiovascular event, and the cardiovascular event can be ischemic heart disease, ischemic stroke. So yeah, and as you know, those are the main cause of death in the entire population in the world.
Yeah. Are there any particular factor as regards the structure of the endothelium or any particular organs in which the endothelium is more likely uh, to integrate LDL or remnant cholesterol into the
Uh,
arterial wall?
yeah, you know, other important risk factors may have also an impact on the risk of the development of atherosclerotic cardiovascular disease, like hypertension, like smoking, like the lack
Sure.
of physical activity. So they may interact, and they sometimes they can provoke some disturbances. For example, hypertension may develop some disturbances in the flow of the bloodstream, plus the high levels of LDL cholesterol or remnant cholesterol. So yeah, it's a mix, and they sum up for the risk of development of the plaque, and finally the heart attack or ischemic stroke.
Yeah, absolutely. I was thinking also, are there any like biochemical structural properties of the vessels in the different organs of the body that make, for example, strokes in the brain and heart attacks in the coronary arteries, that make these arteries in particular specifically susceptible to having these plaques
Yeah,
the result of high LDL or non-HDL rather.
yeah, it's a very important question. To be honest, I am not. I mean, uh, maybe uh, we can find some information about that, but I am not really sure about the specifics of this um, uh, predisposition, right? Of in specific in the endothelium, in the coronary arteries, or in the carotid arteries,
Yeah,
which promotes more. But yeah, I am not really sure. I cannot really develop this answer.
I see, I see. And so other than the uh, manifestation of a stroke or a heart attack, what are some earlier symptoms of having high levels of non-HDL cholesterol?
Yeah, that's very, very important question because, yeah, it's one of the uh, biggest challenges with hypercholesterolemia because it's usually silent, right? Yeah, it would be fine that you may develop some symptoms, but usually it's quite silent. So in most people with high cholesterol levels, they feel completely fine, and that's exactly what makes it so dangerous. There are no obvious symptoms in early stages, no pain, no discomfort, nothing you would notice. So people can go for years and years, even decades, with high levels of LDL cholesterol, remnant cholesterol, non-HDL cholesterol levels, and never know they are at risk until they suffer a heart attack stroke. So that's why it's very, very dangerous, the high levels of those lipoproteins. Now, in individuals with very high levels of cholesterol, for example, those with familial hypercholesterolemia, they have very, very high levels of cholesterol. They We might see some physical signs. For example, these signs include things like xanthomas, which are cholesterol deposits in the skin or the tendons, or something that is called xanthelasmas, which are small yellowish patches around the eyes. Yeah. Some patients may also develop something that is called corneal arcus, and this is a white ring around the iris. uh, but these are rare signs. But when we see them, especially in younger people, they can be clues for this genetic condition. But for the vast majority of people, especially those with acquired or a diet-related dyslipidemia, there are no visible sign, and that's why it's so important to check cholesterol levels regularly, even if you feel healthy. And especially if you have some risk factors like the family history of the lipidemia, the family history of a premature heart attack, of if you have diabetes, or if you have obesity. So, well, in short, hypercholesterolemia is a quiet condition, but it can lead to a very loud consequences. And the only way to catch it early is through the routine screening, like with other cardiometabolic diseases. For me, the thing is that the problem with all the cardiometabolic diseases is that they are usually silent, right? Diabetes is usually also silent. The high levels of blood pressure, it's usually also very, very silent. So that's why these diseases are quite dangerous.
Yeah. And usually when people go to test their lipid profiles, they get answers as regards their levels of LDL cholesterol and triglycerides and so on. But LDL cholesterol and HDL cholesterol in regards to cholesterol specifically, right? And total cholesterol. Uh, do you think that remnant cholesterol, for example, should be integrated into these lipid panels or not? And what?
Yeah, right, right. Interesting question. Yeah. Well, yes, that's true. The traditional lipid panel give us the total cholesterol, the LDL cholesterol, the HDL cholesterol, and triglycerides. And this is very, very useful, and is a valid tool for assessing the cardiovascular risk in most people, in most patients. But also one of the strengths of the normal lipid panel is that it allows us to calculate some other important risk factors. For example, the non-HDL. Normally, the non-HDL is not measured, but it can be calculated. And it's very, very easy because simply you have to subtract HDL from total cholesterol, with no extra cost, right? So it's very important to calculate it. And from there, we can also estimate remnant cholesterol. And it's quite easy because we can estimate it as a total cholesterol minus HDL cholesterol minus LDL cholesterol. And again, with no extra cost. So these calculated values are actually very, very informative, and they are also recommended as a treatment target in current guidelines, particularly in those individuals with type 2 diabetes, obesity, again, metabolic syndrome. But that being said, I would like to introduce something else in the lipid panel. We know we have mentioned that ApoB is the main protein in all the non-HDL cholesterol particles. And the ApoB gives us an even more precise measurement of the risk. And why? Because every atherogenic lipoprotein particle, whether it's LDL, remnant, lipoprotein little a, carries one ApoB molecule. So ApoB directly reflects the number of particles and not just the cholesterol they carry. And that's important because it's the number of particles and not just the amount of cholesterol that drives this plaque formation that we have talked. And finally, and this is an emergency, emergent risk factors, is the lipoprotein little a of LP little a. We have to measure is another yeah, very valuable measurement, and should be measured according to the recent guidelines at least once in life. LP-A is genetically determined, and it can be elevated even when we have a lipid panel normal. So that's why it's important to measure it. So yeah, we have the lipid panel. We can calculate two very important risk factors: non-HDL, remnant cholesterol, and maybe an extra. And if it could be possible, we could measure ApoB. It's quite important, and LP-A.
Right. And so if I understand correctly, LP little a is something that you do not, through lifestyle factors, for example, get
Yeah,
elevated over time, but it's rather a genetically determined.
yeah, is more than 90% genetically determined. So some secondary factors may change the levels of LP-A. Mainly, for example, in the menopause transition, can increase the levels of LP-A maybe 20%. Right? People with chronic kidney disease also may increase the levels of LP-A. People with albuminuria, they also increase. But yeah, the main uh, cause of the levels of LP-A is genetics.
Yeah. And so if we were to integrate LP little a into standard lipid panels, what would be the benefit? Would we be able to treat these patients with statins, or like what would be the benefit of integrating it?
Yeah, also very interesting question. Yeah, and um, statins doesn't really lower the levels of LP-A. In fact, some studies have shown that they can increase to maybe to 5% the levels of LP-A. We don't know the reason for that. So, but we know that the very, very high levels of LP-A can be as dangerous as having this genetic LDL disease, familial hypercholesterolemia. So people with levels of Lp(a) above 180 milligrams per deciliter, those levels are quite similar as having familial hypercholesterolemia. So, and this is an emergent topic. So we don't really know uh, 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 about. I mean, we are discovering many things about around Lp(a), but currently there are some drugs in development and that they can specifically lower the levels of Lp(a). Uh, so at this moment, we have genetic and observational studies that suggest that lowering the levels of Lp(a) may impact in the risk of atherosclerotic cardiovascular disease, but we need the CVOT, the cardiovascular outcomes trials that confirms us that lowering the levels of this Lp(a) will have an impact on the yeah, cardiovascular
Yeah.
outcomes. But maybe maybe 1 or 2 years to have those data.
I see. I see. So currently we have association data and that
Exactly.
the relation.
And also causal information, right? Through genetics. There are many, many studies. In fact, Professor Bow in Northscored in 2009, they published an article in the from the Copenhagen General Population Study, and they made these Mendelian randomization studies, and they showed that the high levels, the genetically determined high levels of Lp(a) is causally associated with the risk of atherosclerotic cardiovascular disease, and at the same time, a group in the United States they also shown through a different method something similar. So and yeah, after some years in the UK Biobank, it was made a similar study with a bigger population, right? And it was shown the same that the Lp(a) is causally associated with atherosclerotic cardiovascular disease, but we we have to wait to the results of these CVOT studies to really understand and or integrate this data.
I see. And that's probably necessary before we can integrate Lp(a) into standard lipid panels, right?
Yeah, also very interesting topic. Uh, the idea at this moment, and it was established and it was recommended by the European Atherosclerotic Society and the European uh, Society of Cardiology, uh, because according to the data we have now, 1 in 5 people may have high levels of Lp(a). So that's a big amount of people. It could be a big amount of people in the world, right? So the idea of measuring Lp(a) is to catch those people. Yes, at this moment we don't have treatment for lowering Lp(a), but at least we can treat the other risk factors. For example, if this individual with high levels of Lp(a), if they have diabetes, if they have obesity, if they have high levels of blood pressure, we should treat more intensively those risk factors, because now we cannot reduce the risk conferred by the high levels of Lp(a). But yeah, we need to treat the other risk factors more aggressive, and this is now the recommendation. But yeah, even we don't have treatment right now in the main lipid societies, cardiovascular societies recommend to measure at least one in the lifetime levels of Lp(a). Now in Mexico City, last year we published a position statement about lipid disorders, and also we recommended measuring Lp(a) in our population at least once in life. And this is also for the United States, for Canada, Europe, and all other countries in Asia, like Japan. They also recommend measuring at least once in life Lp(a).
Yeah, and that's different, right, from HDL and LDL and triglycerides, for example, which you measure continuously or on a yearly basis, for example.
Exactly. Yeah. Because like it's genetically determined. Exactly, it's quite similar if you measure at your 20s or at your 30s or at your 40s, and even uh, for example, the menopause transition may increase the levels. It's not a really big difference because the main reason of the levels is genetically determined.
Yeah, right. Um, so what would be your suggestions for how to improve the standard lipid blood panel? Integrating one per lifetime testing of Lp(a). What would be the other improvements of the lipid panel?
Yeah, well, according to recommendations, the current guidelines of different medical societies. So it is recommended that at least at age 40, you should have a measurement of a lipid panel, right? It can be in fasting or non-fasting, but it's very important to measure at least when you are at your 40 and so on. Uh, but it can be earlier in life if you have some risk factors. For example, now it's more common to see people younger than 40s having obesity, having type 2 diabetes, having metabolic associated fatty liver disease, muscle D, or hypertension. So those individuals, when they have those conditions, they can be at high risk. So in those people, it's important to measure a lipid panel before of 40s, or if they have a family history of premature atherosclerotic cardiovascular disease. And it means that if you have a family member with heart attack, ischemic stroke, if they are men and they develop those diseases before 55 years old, of if they are women and they develop atherosclerotic cardiovascular disease before 66, 65 years old. Uh, Also, it can be uh, something for measuring a lipid panel before age 40s, right? But if you don't have risk factors, you don't have family history, yeah, it could be ideal to measure a lipid panel.
Yeah, yeah. And how, like we mentioned earlier, the components of the currently standard lipid panel, which is triglycerides and different cholesterols. And how would you, other than uh, once per lifetime, adding Lp(a), how would you improve upon the current standard lipid panel to make
Yeah,
it even more useful in finding patients at risk for cardiovascular uh, events and coming in then earlier with the treatment for these patients?
yeah, yeah. Maybe one of the thing is that maybe, for example, general practitioner, they see many people, and they are the first contact with patient in the general population. And sometimes in the general practitioners, they don't really know about the impact of the lipid disorders on the risk of atherosclerotic cardiovascular disease. And hypercholesterolemia is one of the main drivers in the development of heart attack, ischemic stroke, plus hypertension, diabetes, but hypercholesterolemia is at least the second most important risk factors. The thing is that exactly sometimes in the general practitioners area, sometimes they don't look or they don't measure at lipid panel, and even more sometimes they cannot really interpret the results, right? Uh, you sometimes you may have normal values when when you measure lipid panel. You can find some um, normal values, but the normal values regarding LDL cholesterol, it's different according to your risk. For example, if you are at low risk, the normal values of LDL cholesterol is below. I am talking in milligrams. Sorry for that. Is below. I mean, you need treatment if you have values above 130 milligrams per deciliter. If you are a moderate risk, you need treatment, for example, with statins, if you have LDL cholesterol above 100 milligrams per deciliter. If you are a high risk, you need treatment when the levels are above 70 milligrams per deciliter. But if you are a very high risk, you need treatment if you have levels above 55 milligrams per deciliter. So it's very different according to your risk. But if you only follow the normal values you can see in the lipid panel, so maybe you are not giving the correct treatment at the correct time to the correct patient. If this patient have type 2 diabetes, if they have a damage to let's think we have a people with type 2 diabetes with yeah, 10 years uh, uh, of diabetes, and they have chronic kidney disease or related to diabetes. So they are patients with very high risk. So they need to have levels of LDL cholesterol below 65 milligrams per deciliters. But if you see the normal values, and the normal values are to 130 milligrams per deciliter, you can think, okay, these patients maybe don't need a treatment. So that's what I refer when I say that sometimes there is no enough information
Mm.
about lipids, and something that also it's very frequent is the clinical inertia when you have some high levels, and sometimes you don't uh, intensify the treatment to reach the values a particular patient needs. So yeah, there are many factors around the lipids, and not only about measuring them correctly, but also treating them correctly, or doing a correct interpretation of the lipid panel.
I see, I see. So you think that the interpretation of the lipid panel and also the consideration of other risk factors into the decision of whether to treat based on a specific lipid panel results, um, that is where the most improvement as regards clinical decision making can be done.
Exactly, and that's why I think this kind of podcast, what you are doing, I am now working on also a podcast. It's called Lipid Talks, and we are talking about lipids for the general practitioners, because we think that in Mexico we need people need more accurate information about the lipid disorders, right? So, and in the past, it was very difficult because the medical guidelines, they have some calculators to yeah, to calculate the cardiovascular risk, and they used to be sometimes quite difficult to understand. uh, but currently, the European Atherosclerotic Society and the European Society of Cardiology, they develop more easy ways to calculate the risk, like very high risk, moderate risk, low risk. And you don't need these very complex risk calculators.
Yeah, I know that score 2 is the model that we were taught in our medical school.
Exactly,
Yeah.
exactly. But also you have some established, for example, the European Society of Cardiology, they say, okay, if you have familial hypercholesterolemia plus one risk factors, you are in very high risk. So you don't need to go to a score 2 and to calculate the risk.
Mm.
Instantly, you are a very high risk of, if you have diabetes plus damage to an organ, for example, the kidney, the eyes, instantly you are at very high risk, right? So it makes easier to integrate, and you don't need to go and to calculate with different factors. Or if you have type 2 diabetes, type 2 diabetes, long type 2 diabetes, plus one risk factors, you are in high risk, right? So it makes easier.
Yeah. If you have those particular conditions, right, then it's
So
easier to.
if you are seeing patients, if you are in the clinic, and sometimes you don't have enough time, right? So if you integrate those information in some seconds, you establish the cardiovascular risk for that particular patient, and you can improve their risk factors, because if you categorize them, for example, like high high risk, so the targets are different, as I mentioned, for LDL, but also it can change for the other target, for example, hemoglobin A1C, the levels of blood pressure, the BMI, etc.
Right, so it's a stratification into different levels depending on other factors, right?
Exactly. Yes.
Yeah, yeah. Okay, so I want to move on a bit to testing the actual blood draw and the quality of the data that you get from that as regards cholesterol measurements. And specifically, I want to discuss fasted state measurements versus measurements done after a mixed meal tolerance test. Can you explain what that is and why it might be useful in this context?
Yeah, yeah, of course. Well, the standard fasting lipid panel has served as well, as I have mentioned, but it has, yeah, limitations. Mainly that it captures, is like a snapshot of the body in the fasted state. However, humans spend about 75% of their time in a postprandial state, right? So maybe it's not a good idea to measuring the lipid panel on fasting. On the other hand, the mixed meal tolerance test allows us to evaluate how the body handles lipid after eating, and this is particularly important because postprandial lipemia especially elevated triglycerides and elevated remnant cholesterol, is a strong marker of atherogenic risk, but especially in people with insulin resistance, metabolic syndrome, or diabetes. So yes, while it's not yet standard using standardized mixed meals to study postprandial responses could give us a more accurate insight into real life lipid metabolism and cardiovascular risk. However, in clinical practice, we can take the lipid profile in a non-fasting state, and we can also capture the postprandial state, right? In countries from Europe and North America and some countries in Asia, taking the lipid profile in non-fasting is the standard. And the mixed meal tolerance test is used frequently in research setting because this is quite laborious, and it's also expensive. But if you measure the lipid panel in non-fasting, yeah, you have very, very good information.
Hmm.
Yeah, and the recommendations in the world are now changing. I mean, uh, maybe 20 years ago, all lipid panels in the world uh, used to be measured in the fasting state, but currently it has been changing.
Okay, so there are no issues with taking cholesterol levels in a non-fasted state?
Yeah, I mean, the levels of cholesterol are similar in fasting and non-fasting. The 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 levels of triglycerides, they increase
Right.
during in the non-fasting state, right? Compared with the fasting state. So if you take the if you measure a lipid panel in non-fasting, and you find very high levels of triglycerides, let's say uh, above 4 millimole per liter, or in the international units above 400 milligrams per deciliters. So you can repeat the lipid panel. You can ask the patient to come a different day in fasting, right? But to only measure triglycerides. So because the rest of the cholesterol is quite similar. It's very stable in fasting and non-fasting.
Right. Right, because it also takes, like, several weeks for
Yeah,
cholesterol to change significantly, right?
exactly. And that's why, for example, when you prescribe lipid lowering therapies to patients, for example, statins, that they are maybe the most important lipid lowering therapies, you wait some weeks after you can see a real change in the lipid levels. You usually wait 4 to 6 weeks before you can see a real change. So yeah, it takes some weeks to change the lipid panel, unless you are in, for example, uh, if you have a disease like an infection disease, it can lower the levels of, for example, cholesterol and LDL quicker, right? But in the, I mean, in people, in healthy people, yeah, you can do it in fasting, non-fasting. Currently, the main guidelines in the world is they suggest like measuring the lipid panel in non-fasting.
Right, right. Um, and so I want to focus in on a specific study that you uh, played a role in publishing. And the finding in that study was that higher remnant cholesterol better explained the variance in cardiovascular disease. And these were patients with chronic kidney disease, better than LDL. So remnant cholesterol was better than LDL for explaining the variance in cardiovascular disease. Uh, why do you think this is? And do you think that these findings are likely applicable to the general population as well, and not only to patients with chronic kidney disease?
Yeah, that's right. Yeah, this study, it was published last year in ATBV, and yeah, we found that we analyzed the Copenhagen General Population Study, that it has more than 110,000 individuals included, with a follow-up of uh, almost 9 years. And yeah, we found that remnant cholesterol was more strongly associated with cardiovascular outcomes than LDL cholesterol, but specifically in individuals with chronic kidney disease. Why? Well, because in chronic kidney disease and other diseases like insulin resistant states, triglyceride-rich lipoproteins clearance is altered, and remnants tend to linger in the bloodstream. These remnants are smaller, cholesterol rich, and they are very, very atherogenic. So they easily uh, can enter the arterial wall and promote inflammation, the plaque formation, and finally the risk of ASCVD, atherosclerotic cardiovascular disease events. Well, but of course, LDL cholesterol is so important in the general population, right? And in most people, because LDL cholesterol is quite abundant. And that's why all the international guidelines recommend that the LDL cholesterol should be the lipid target to reduce the risk of atherosclerotic cardiovascular disease. But in specific settings, remnant cholesterol might be a better marker. Like individuals with diabetes, we have information for people with diabetes, and we have now information for people with chronic kidney disease. And well, now, even though chronic kidney disease is a specific population, I do believe these findings are highly relevant in other specific populations, especially in regions like Latin America, where remnant-driven dyslipidemia is so common. So yes, the concept applies more broadly, but it highlights the need to look beyond LDL cholesterol, right? We are not saying don't measure LDL cholesterol, forget about LDL cholesterol. No, no, no. We know that it's LDL cholesterol is the cholesterol, right? The important thing. So in our paper, we conclude that in non-statin users, LDL cholesterol and remnant cholesterol explain together the excess risk of atherosclerotic cardiovascular disease. However, we found that in statin users, remnant cholesterol explain the excess risk of atherosclerotic cardiovascular disease and not the LDL cholesterol. So it shows clearly the residual risk for atherosclerotic cardiovascular disease, and this is an unmet need since currently we don't have therapies for that, right? But also in our paper, we recommended that calculating non-HDL cholesterol and ApoB, it might capture all the atherogenic cholesterol and particles, including the LDL cholesterol, but also remnants. So, yeah, I think the findings are very, very interesting, and we are trying to say, yeah, okay, LDL cholesterol is very important, but please let's see beyond LDL cholesterol. We have other lipoproteins that may explain the residual risk: remnant cholesterol, Lp(a), right? Inflammation, diabetes, hypertension,
Yeah,
etc.
yeah. And so, do you think then that remnant cholesterol might not be so relevant for a standard lipid panel, but rather for patients with, for example, diabetes or chronic kidney disease as a test to take then in those circumstances?
Yeah, but I think that in people, for example, in uh, uh, l- I am talking about, for example, Mexico. Mexico, the main lipid disorders is the high levels of triglycerides. But this means that high levels of triglycerides, it means that the levels of remnant cholesterol are also high, right? So, and there are many studies, uh, yeah, including very, very important information from the Copenhagen general population with Professor Bow, and they confirm the causal and observational association of remnant cholesterol and the risk of atherosclerotic cardiovascular disease, right? So we have, again, we have genetics, we have observational studies, and we need the last step. We need the clinical trial that confirms that reducing the levels of remnant cholesterol may have an impact in reducing the risk of atherosclerotic cardiovascular disease. I do believe that the high levels of remnant cholesterol, they have a very important impact on the risk. And I do believe that in Mexican population, where we have that the prevalence of high levels of triglycerides is almost 50% of the entire population. I mean, 50% of the entire population may have levels of triglycerides above 150 milligrams per deciliters. And it means that the levels of remnant cholesterol uh, might be also high, right? So, and that's different from other cohorts in Denmark, in the UK. So yeah, now currently I am trying to run some studies specific for the Mexican population to also confirm that association. And I really do believe that remnant cholesterol, it's a very important lipoprotein that confer a high risk for developing atherosclerotic cardiovascular disease.
Right, right. Do you think then that it should be included in standard lipid panels used by general physicians as well, like in people who don't have diabetes or chronic kidney disease, for example?
Yeah, completely. Yeah, I totally agree with that. And for example, in Copenhagen, it's part of the standard, right? And because it's very easy, you only have to calculate remnant cholesterol. You don't have to measure. You don't need an extra cost. You to the total cholesterol, remnant cholesterol is total cholesterol minus LDL cholesterol minus HDL cholesterol, and those lipoproteins are in the lipid panel, right? So
Right, right.
you don't need nothing else, just to put a formula, right? And it can be calculated automatically. And yeah, now I am trying also to implement this in Mexico City, at least in our lipid clinic, because yeah, we have the standard lipid panel. We also measure a lot ApoB. We measure LPA. We measure automatically non-HDL cholesterol, and I do believe that it could be very, very useful to also calculate remnant cholesterol.
All right. So I was thinking we could go through some factors that might modulate non-HDL cholesterol, and we've already mentioned that it takes several weeks to significantly uh, alter the levels of non-HDL cholesterol in blood. But if you could give an estimate of the magnitude of the effects of these various factors when I mention them, and the strength of the evidence for whether or not these factors can influence non-HDL cholesterol, that would be great. Okay, so saturated fatty acids do increase non-HDL cholesterol if you have large amounts of it in your diet. How about money and polyunsaturated fatty acids? How do they impact cholesterol levels?
Yeah, that's a very important question, and that's why some medical guidelines recommend eating more mono and polyunsaturated fats, like those coming from olive oil, for example, nuts, fish. And what, at least what I know, is that it reduces, may lower the levels of non-HDL, at least 5 to 10% I mean, dietary facts, they don't have a really impact on cholesterol levels. Um, Dietary factors have a more impact on triglyceride levels, but not on cholesterol, because most of cholesterol in our body come from the liver, the production of liver, and only 1/4 of the cholesterol come from the diet, right? So it doesn't mean that we can eat all fat we want, whatever. As you have mentioned, saturated fats, it's very bad because it increases LDL and non-HDL levels. The mono and polyunsaturated fats may have an impact lowering non-HDL, but yeah, the amount is not quite significant. Maybe 5% to 5 to 10%, and even maybe in a very uh, good combination of nutrients, maybe you can reach 15%, right? Uh, but for example, in people with familial hypercholesterolemia, those they have very high levels of LDL cholesterol and non-HDL cholesterol. Of course, we recommend yeah, dietary to do a diet, right? But we also need to add lipid lowering therapy, because let's think, a patient with levels of LDL cholesterol in 250, that it's common and not, it's not really really high. Eh, and if you prescribe dietary factors, maybe you can, yeah, reach in yeah, in, if the patient follow these dietary recommendations, maybe you can lower 25, 30 milligrams per deciliter, right? Maybe you can reach 220, 210 milligrams per deciliter of LDL cholesterol. But maybe this patient need a target of LDL cholesterol below 70. So you are still, yeah, you need something else than dietary factors. But again, this is for only specific population, right? Familial hypercholesterolemia, whatever. But for the general population, and the recommendation is that yeah, you have to avoid as much as possible saturated fats, because they not only increase the levels, but they can also promote inflammation. They can also promote that these lipids can be oxidized more easily. So compared with mono or polyunsaturated fats, that they reduce, they lower the levels of LDL and non-HDL, but also they are associated with a more healthy profile in your body, right?
Right. And how about different sources of caffeine, such as tea and coffee? Do they
Yeah,
increase cholesterol?
yeah. Maybe the evidence is that is only it may have a neutral effect on lipid levels, right? But there are some evidence regarding yeah, taking caffeine, coffee, uh, with the reduction of some cardiovascular events. So currently, it's recommended taking 2 or 3 cups of coffee, and it is associated with a lower risk of cardiovascular events. But the specific the mechanism behind this recommendation is well, what I know is not really. We don't know about what's the mechanism behind that, right?
Right, right. And so it's not clear that it's through cholesterol that the lowered incidence of cardiovascular events in people who drink 2 to 3 cups of coffee. It's not clear that it's due to cholesterol lowering effects.
Exactly. Maybe it's not exactly related with the lipid profile. Maybe it's through other different mechanism.
Yeah. I remember reading, actually, here in Uppsala, there is some research that has been published quite recently, actually, on the um, effects of filtered versus unfiltered coffee on cholesterol levels. And the finding was that unfiltered coffee raised LDL cholesterol
Okay.
in this
Wow.
recent study here in Uppsala. Um, and so, and there was also this finding that coffee made in machines at the local hospitals, at least in Sweden, how they make coffee in those machines. They produce coffee in such a way that caffeistol, for example, which is a compound that is inside of unfiltered coffee, then um,
Okay.
it was present in higher amounts, and that resulted in increases then in LDL cholesterol. So I guess
Wow.
it might depend on what type of coffee and particularly how it's prepared, what the
How
effects.
much is the increase? Do you know how much is the increase of LDL cholesterol?
Oh, let me check. This is fun research, right?
Okay. It's quite interesting.
Yeah. Yeah, so replacing 3 cups of brewing machine coffee with paper filtered coffee 5 days per week was estimated to reduce LDL cholesterol by 0.58 millimoles per liter.
Okay. So it's significant.
Yeah.
Wow.
And this is these are the machines that are used at at hospitals and in primary care units in Sweden. So I don't know if it applies worldwide, but my guess would be maybe, yeah.
Interesting. Yeah, I didn't know about that information, but yeah, I will try to check more. Yeah, but I knew about the impact of coffee was like more coffee and tea, for example, is like it was more neutral, right, on lipid disorders, and maybe the mechanism behind the protective um, capacity was related maybe with other different mechanism. But yeah, and I am not really expert on
Yeah,
that topic.
I see. And I think that's the general consensus as well as regards coffee and tea in general, but uh, in particular, then uh, coffee that is not filtered appears to raise LDL cholesterol with 0.58 millimoles per liter.
Wow, that's very important. I mean, yeah, it's like 20 milligrams per deciliter. That's very important.
Yeah, and that's 3 cups per day, 5 days a week. Uh,
Okay.
is is what they made that estimate from. Yeah.
Okay.
All right. So how about alcohol? Does it impact cholesterol levels?
Yeah, that's a very interesting topic, because for years it has been, yeah, some evidence found that, yeah, some small amounts of alcohol, mainly sometimes wine, for example, red wine, could have an impact on lipids, on lipids profile, but mainly rising the HDL cholesterol, right? And saying that HDL cholesterol is like the protective cholesterol. Now we know that the levels of HDL cholesterol is not really predictive of or is not a target to reduce the risk of atherosclerotic cardiovascular disease, right? But maybe alcohol may improve the function of HDL. Now we know that the function of LDL of HDL cholesterol instead of the concentration of the cholesterol of the HDL cholesterol could be even more important because there are some studies, uh, some clinical trials that increase the levels of HDL cholesterol in specific population, mainly in high risk population, people with atherosclerotic cardiovascular disease, uh, and raising the levels of HDL cholesterol didn't have an impact on the cardiovascular outcomes. When we say the studies with statins, reducing LDL cholesterol have a really impact in reducing cardiovascular events, but increasing HDL didn't have an impact. So now we are more focused on the function of HDL, and it means because HDL may have some antioxidant, anti-inflammatory properties, mainly because the protein of HDL that is called ApoA, and the levels of ApoA has been associated with um, antioxidant, anti-inflammatory features. So the theory behind the alcohol consumption is that um, small amounts may raise levels of HDL cholesterol, but also to improve the function, the antioxidant capacity of HDL. The thing is that also alcohol increase levels of triglycerides, right? And higher amounts of alcohol may have an impact on liver disease, may increase the risk for steatosis. So uh, currently, alcohol consumption is not a real recommendation for the prevention of atherosclerotic cardiovascular disease, right? And the recommendation is that if you take it, you should take only a small amount, and not with the idea of improving your health, whatever, but maybe only for having fun, right? But no,
Sure.
not really for protection.
Yes, I see. How about sugar?
Yeah, for sure, sugar, but mainly this kind of refined sugar that we can find in ultra processed food. They are the major or the main drivers of high levels of triglycerides and remnant cholesterol. That's why I do believe that because in Latin America and Mexico, we have a very high consumption of sugar, mainly in sweetened beverages. So and we have a lot of evidence that the higher the sugar consumption, the higher the levels of triglycerides and also remnant cholesterol. So and it depends on the amount of sugar you have, and also it depends on the genetics. I mean, it's not the same someone with a predisposition for high levels of triglycerides having, for example, a Coke, that someone without a polygenic predisposition, and they take a Coke, for sure they increase the levels of triglycerides compared with someone without this polygenic predisposition. Maybe they if they take a Coke, maybe of course the levels will increase, but not in a very, very important amount.
I see. I see. So it depends a lot on your genes, and in this instance, not a particular gene, but rather many different genes.
Exactly. For example, we have in the lipid clinic, we have some patients with something that is called familial, with yeah, someone is called familial chylomicronemia syndrome or multifactorial chylomicronemia syndrome. And when you talk with them, you sometimes find them with levels of triglycerides above 1,000. That it's a lot, more than 10 millimoles per liters. And when you talk with them, sometimes they frequently they make a good diet, but sometimes they eat something else, and that's enough for increasing the level of triglycerides to a very high level, right? And you can find people with that predisposition, right? You can hear them that they can drink one or two cokes plus sugar plus some cookies plus blah blah, and the levels of triglycerides are not really high.
I see. I see. Right. And if you were to give the listeners 1 to 3 pieces of advice for how they can live their life so as to reduce the risk of developing, well, high cholesterol levels, and then with that risk for developing cardiovascular diseases later on.
Yeah, that's a very important question. First of all, I think it's key to check, right? To check lipid levels. I mean, if you have risk factors, you can do it early in life. I mean, if you have a family history of familial hypercholesterolemia, you have to check your lipid panel having 2, 3, 4 years old, right? And you should start treatment in having 6 or 8 years old. It's recommended the treatment with the statin. So it's very important to check the lipid panel. Uh, and why it's important to check? Because you don't have to wait symptoms, right? If you have something with a tooth, for example, you will have maybe it will be painful, it will be swollen, you will have symptoms, but don't wait symptoms with high levels of cholesterol. Don't wait symptoms with high levels of triglycerides, unless they are very very high, very high the triglycerides. So check yourself as soon as is possible. If you don't have risk factor, at least begin checking having 40 and so on, right? So check your lipid levels. Second, uh, it's very important to think that if you have high levels of cholesterol, the longer you have high levels, the higher the probability of developing atherosclerotic cardiovascular disease, right? So we need two conditions to develop atherosclerotic cardiovascular disease is having high levels, but time.
Mm.
Longer, the higher the risk. So there is a concept that is called the accumulated risk, right? So it's not the same having 1 year high levels of cholesterol that having 20 years, right? So it's very important that if you are diagnosed with high levels of cholesterol, please take the treatment, pharmacological changes in lifestyle, wherever is the recommendation for you, and don't wait like okay, I feel fine, so I will stop taking the medication. No, think that you have to take the medication for a long time. So please visit your doctor and talk with them about for how long should be prescribed that medication. If they say it's for, yeah, for the rest of the life, please do it, because otherwise, more time you have the levels in high levels, more the risk of um, ASCVD. And maybe the third recommendation is, please don't forget the other risk factors, right? Sometimes we only focus on lipids, right? If I am an endocrinologist, maybe I am more interested in checking the target of LDL cholesterol, non-HDL cholesterol, right? Maybe hemoglobin A1C, because I am biased, because yeah, I am focused more on those diseases. But remember that the body is yeah is one. So you need to check blood pressure, you need to check your weight, right? You need to check also stress, the lifestyle, right? If you are you're a smoker, if you exercise, if you have good habits, right? Eating habits. So uh, so it's very important to really take into account all the risk factors and treat them in order to avoid, yeah, a cardiovascular complication in the future.
Yeah, right. So I want to move on to um, a bit about the research that you're doing and whether there are any myths about cholesterol and high levels of cholesterol that you hear people say that you think are just not true, that you'd like to bring some clarity on.
Yeah, true. Yeah, that's a very important question. Yeah. Unfortunately, even though, for example, I would like to focus on treatment, specifically statins, right? So statins shown that they reduce levels of LDL cholesterol, and they have a very important impact on reducing the risk of atherosclerotic cardiovascular disease. Some of the statins in the development of them, yeah, they had some side effects, right? But yeah, the investigation of those statins stopped, and they were removed from yeah, from the clinic. However, in 90s of last century, uh, on the media there were kind of fake information regarding that using statins could be associated with risk of developing liver diseases, mainly liver diseases. And you can still, if you check the media of that time, yeah, you can find some newspapers talking about that topic. So for some people, they do believe that taking statins may be associated with. They are concerned, and I can understand, right? I can really understand that they are concerned, but it's very important for for them to know that statins are very important therapies for the prevention of atherosclerotic cardiovascular disease. Uh, well, making something similar, I mean, is not maybe the best example, but let's think about the vaccines, right? The vaccines for COVID, right? Uh, we we have a shot of COVID vaccine, and it protects us for developing the severe form of COVID, right? For example, severe pneumonia for with COVID. So it could be similar with statins or some other lipid lowering therapies. I mean, you don't have to wait until having a heart attack to take the medicine or to do something, right? It like you don't have to wait until you get COVID to get the vaccine, right? So if you know that the high levels of cholesterol are associated with the risk of atherosclerotic cardiovascular disease, so you can make a prevention, but the prevention is not um, uh, uh, taking the medicine 1 year, 2 years. Sometimes is to take the medicine for a long time, right? So the second myth, but well, for the third myth, the information we have now is that statins, the main treatment for high levels of cholesterol, are quite safe. And they are now, you can find them in low, the cost is now very, very low in most of countries. Second myth is that the very low levels of LDL cholesterol might be associated with cognitive disorders, right? And because some studies shown, some anecdotic studies shown that kind of association, right? So for some people, they are concerned that taking statins, but not only statins, other type of lipid lowering therapies called PCSK9 inhibitors, that they can reach very, very low levels of LDL cholesterol. I mean, levels of 1.5, for example, millimole per liters, like 20 milligrams per deciliter, that it's quite low. And yeah, I can really understand the concern about that, but we have now evidence through studies with at least 3 years follow up that have confirmed that very low levels, for example, below 30 milligrams per deciliters of LDL cholesterol, was not associated with many uh, with cognitive disorders, right? And it was evaluated through different mechanisms, right? So at this moment, we know we have enough evidence to say about LDL cholesterol and non-HDL cholesterol. The lower, the better,
Yeah.
right? So yeah, for people, you must be sure that having not necessarily very low levels, but having the good levels of LDL cholesterol is more important. Of course, statins or lipid lowering therapies may have some side effects, right? But the main side effects of those therapies are mild. So, and it's very, very rare to find very severe side effects. But uh, in a balance, right? The the benefit of using them is higher than the risk of having an important side effect.
Yeah. Yeah. Um, and that's quite uh, interesting to hear, considering that, as you mentioned in the beginning of the conversation, cholesterol is used, for example, in the brain. But still, I guess then that 1.5 millimoles per liter or 20 grams per 20 milligrams per deciliter, was that the
Yeah,
yeah? That is enough for what the brain needs, so to say.
yeah, exactly. But exactly, the other thing is that brain produce its own cholesterol. I mean, exactly because almost 25% of the cholesterol in the body is in the brain, right? So it's a really big amount of cholesterol. But almost all the cholesterol produced for the brain is produced by the brain itself. So the brain really doesn't need the cholesterol of the of plasma. And the cholesterol in plasma, you need only very low levels of cholesterol to produce hormones, for example. So there was a concern about if the levels of testosterone, estrogens, that they are made of cholesterol, could be low. And now we have evidence that we need only uh, yeah, very small amount of cholesterol to produce vitamin D, all the hormones, whatever. So at least at this moment, we don't have evidence of having an important problem, having very low levels of LDL cholesterol. But we have enough information about the importance of having low levels of LDL cholesterol for reducing the risk of
Exactly.
atherosclerotic cardiovascular disease.
Yeah. And were there any findings when you started doing research in this field and um, during the progression of your career within this field as a researcher, as you published study after study? Were there any surprises for you as regards the results of your studies?
Yeah, to be honest, I mean, I really love research because I always get surprised with everything. I mean, what I accept is that a human body is amazing, right? So it's very complex, and we are trying to check the details about how it functions in the normal way, but also in different scenarios, like in environment with a very high consumption of sugar, but also what happens with people taking yeah, larger amounts of alcohol, or those people who smoke, or those people with obesity. So yeah, I can say that I always get surprised when I try to answer a clinical question, and I do research to try to answer that questions. I always get surprised about results, right? Sometimes I am expecting some results. I can say that those results we comment about, that remnant cholesterol was more associated, that LDL cholesterol, on the risk of ASCVD in individuals with chronic kidney disease. I was like, I mean, I expected that, right? I was like, because of the all the background we had, but at the beginning I was like kind of skeptical about if we would have the, the the result we were expecting. And it was impressive because when we made all the sensitivity analysis, I mean, when we got the main results, I was like, wow, this is amazing. But we made different sensitivity analysis, right? And in all the sensitivity analysis, we found exactly the same, right? So we adjusted for many factors: diabetes, for BMI, body mass index, for LPA, etc. For yeah, the use of statins, and it was always exactly the same. So yeah, and that's why I really enjoy doing research. I know that sometimes you will be disappointed with some results, right? Because you are expecting some results, and yeah, I am sure I will be disappointed sometimes. But at least at this moment, I am really happy with the result we have gotten.
I see. And if there were unlimited resources available to you and you had all the funding you could ever need for one study, you could choose one study to make within this field. What would your research question be that you wanted to answer?
Ah, wow. That's a very that's a challenge for me. Yeah, yeah. That's very interesting. Maybe it it could be something related, maybe not only with lipid disorders, but maybe something broader. Maybe I would like to include something related to obesity, right? That it's a very, very important health problem in my country. So, and it's one of the main drivers for the development of dyslipidemia, of lipid disorder, hypertension, diabetes, muscle D. So, I would like, maybe if I would have all the fundings, yeah, I would like to do uh, some strategies to reduce the prevalence of obesity in my country, and something more generalizable, right? Not uh, something specific, something, um, yeah, some strategies that could be for the general population, right? But with a high impact, right?
Yeah.
On obesity, because, yeah, for me the main problem uh, behind all the cardiometabolic diseases is obesity.
Yeah. Yeah. I think that's a good answer. Um, if you, if the listeners could take away just one message from this conversation, what would you like that to be?
Yeah, please prevent cardiovascular disease. Is the main cause of death worldwide. Um, all the risk factors, including high levels of cholesterol, usually are asymptomatic. Diabetes, hypertension, lipid disorders, they are usually asymptomatic. Please don't wait until you have a complication. Please check, check, check when possible, right? Check blood pressure, check glucose, check lipid panel, and if you have something, please treat from the first day until your doctor says stop the medication, right? Otherwise, please take it, take it. I can understand your concerns about some side effects of some drugs, right? But we always, I can say that as a clinician, someone who sees patients, when I prescribe one drug, I always put in the balance, right? The pros, the cons. Obviously, if the pros are higher than the cons, I prescribe the medication, right? So,
Yeah.
yeah, I would be it would be my message for people.
Good message, I think. Do you think that there are any groups of patients who don't need to get tested? Like, I'm thinking, for example, young people without symptoms maybe don't have to get tested every year.
Exactly. Yeah, exactly. If you are young, if you are younger than 40 and you are lean, if you are healthy, if you exercise, if you eat well, yes, you don't need to worry. And if you don't have a family history of cardiometabolic diseases, yeah, maybe you can check yourself after, yeah, starting 40s, right? Yeah, you don't have to be concerned. But if you have a high body mass index, plus family history, plus you smoke, plus you drink a lot of alcohol, maybe I would try to do it maybe earlier.
Yeah, right. Where can people learn more about your work?
Yeah, please, I invite you to follow me on LinkedIn. It's very easy. It's just Daniel Elias. You can find me there. And, well, in the last 2 or 3 months, I have been a bit absent, but I will try to put more information about what I am working on, what I am doing, some. projects I am working. Unfortunately, even I am working on this podcast that they are called Lipid Talks, but they are in Spanish, so it's not. I mean, if they speak Spanish, are more than welcome to look on Spotify our episodes. We have now recorded 5 episodes, right? And it's also we try to make those episodes not very complex, right? So that, but yeah, the focus is on the general practitioners, right?
Yeah.
So
Okay.
and maybe I think LinkedIn, Spotify, and that's it.
Yeah.
Yeah.
I'll make sure to include links to your LinkedIn and to the Lipid Talks podcasts in the show notes of the podcast episode.
Thank you. I appreciate it.
Yeah. And thank you, Daniel, for coming on the Exploring Health and Medicine podcast.
No, thank you for inviting me, and see you later.